Welcome everyone, and welcome to today's Quality Essentials webinar. We're going to give it just a few more seconds to allow everyone to join, and then we will get started. All right, well, good afternoon, everyone. Welcome to our PQA Quality Essentials webinar. Today's webinar is focused on the PQA-endorsed measure, persistence to basal insulin, and this is a health plan performance measure. Before we get into today's presentation, I'd like to review just a few housekeeping points. First, we welcome questions from the audience, so please do submit your questions using the Q&A feature at the bottom of the screen at any point. We also have reserved some time towards the end of the webinar for our speakers to address your questions. So keep that in mind and keep the questions flowing. Also, the webinar recording and slides will be available to PQA members within a week, and you can access those documents and recordings from the member resources section of our PQA website. The recording also will be available from our PQA YouTube channel. And last, your feedback is really important to us. So I encourage all attendees to complete the quick 1-minute survey that will appear at the conclusion of today's webinar. And now I'd like to introduce our speakers. Rachel Digmann is our Senior Director of Performance Measurement. Ben Shirley is Director of Performance Measurement. And I am Lynn Pezzullo, Senior Director of Quality Innovation, and I'll be serving as the moderator for today's webinar. First, we're going to hear from Ben, who will share some background and an overview of the PQA persistence to basal insulin measure, including details on the persistence methodology used within that measure. Then Rachel will review the measure specifications in detail. And before we move to audience questions, our speakers will address some of the frequently asked questions that our team receives related to this measure. And with that, Ben, I will hand it over to you.
All right, thanks so much, Lynn. Quick audio check. Can you hear me okay?
I can.
All right, great. Well, thanks so much, Lynn, for opening this up. Thanks, everyone, for joining today. We're really excited to have you on and talk a little bit about a measure that's more new to PQA, but is very important, addresses a very important area, and is already seeing use in important programs. So this really is a great chance for us to give some information about the measure and maybe answer some of your questions. And I think it makes sense to start with a little bit of background around the development of this measure. So it was developed really to meet a specific need for quality measurement in the insulin space. So this is an area where there's been a noticeable gap in federal quality measurement programs. And you'll also, for those familiar with PQA, notice that PQA's proportion of days covered diabetes all-class measure does not include insulin. So in the diabetes PDC measure, that really relies on the days supply field on prescription claims. And that field, unfortunately, doesn't work so well for injectable medications like insulin due to the associated dosing changes, different usage patterns, et cetera. So since we can't include them in PDC diabetes, there's really been this longstanding interest in this population that hasn't had quality information captured on them around medication use quality for insulin. And obviously, this is a very important cohort. Insulin's a key therapeutic asset in treating diabetes, so our goal really was creating a quality measure suitable for performance programs that assesses insulin use. So to get started on this effort, PQA convened a multi-stakeholder panel back in 2016 to identify potential methodologies. This panel identified a persistence methodology actually created by Dr. Wei et al. In 2014, and we identified that as an ideal candidate. We also looked, however, at a adjusted adherence methodology, a PDC methodology created by Dr. Slaybaugh et al. Even though each of these were looked at independently in the data and evaluated in their own publications, PQA actually thought that it was necessary to do further exploration of these. And so we did our own independent analyses on both the Wei methodology, which is persistence, and the Slaybaugh methodology, which is adherence. And what we found was actually very, very promising, specifically for the Wei methodology. So we saw that persistence measured using that approach is associated with reduced A1C, lower utilization and costs, and other outcomes of interest. So because of that, right, we identified this whey methodology as the ideal candidate for the measure moving forward. But certainly the road of development did not end there. We still had several years of work left in front of us. We continued forward with pre-development feasibility testing for a measure concept based on the whey methodology. So really just focusing on better understanding if we can actually make this type of concept work with prescription claims data. That feasibility testing, as it turned out, was very positive. So we saw that this is something that's feasible to do using the data sources available and using the data assets that are available to most measure users. So what we did then was move the measure into what you might call our traditional measure development process. That's probably going to be pretty familiar to a lot of you. So we convened a technical expert panel to refine the measure concept into a concrete set of specifications. We engaged in thorough measure testing with multiple partners, external testers to better understand the measure reliability and validity and performance. And then finally in 2021, the measure received PQA endorsement. So the end of the road and the start of the road of implementation, maintenance, and the rest of the PQA measure life cycle. Before we jump into the whey methodology and get into some specifics, I think it's helpful to preempt a question that I bet a lot of you are asking yourselves, and that is, what exactly is the difference between adherence and persistence? So PQA has lots of adherence measures, right? You're probably very familiar with the proportion of days covered or PDC methodology. But what makes a persistence measure different than an adherence measure? And this is an excellent question. It's one that a lot of people have. And I think it's useful for me and for others to sort of think about this and answer it two different ways, conceptually and sort of a more technical lens. So conceptually, medication adherence really can be defined as the degree or extent of conformity to recommendations about taking a medication with respect to things like timing or dosage or frequency. Whereas persistence, is really going to focus on the act of continuing treatment for the prescribed duration or not discontinuing. So for some of you, that answer is going to be helpful and it's going to help draw a distinction, but some of the others might be scratching your head, especially if maybe you're thinking about, well, how do I design the logic to make this measure work? What does a program capturing this measure look like? And I think that that's where the technical definition can be very helpful. So if you think about this adherence concept, which is broad, right, that PQA uses to focus on the proportion of days covered in our medication use measures, what that's really looking at is the extent to which a given patient has medication on hand during each day in a given treatment period, right? So that is a continuous variable that ultimately then is dichotomized sort of at the end of the process when you apply that 80% threshold, or it could be a different threshold depending on the specific PDC measure. Those thresholds are based on the clinical evidence. But when you think about persistence, what that really focuses more on is whether or not an individual discontinued. And that is an inherently binary outcome. It's not a continuous variable about how much a given patient adhered during a period. It's just whether or not they discontinued or whether or not they persisted. Those are two ways of sort of the two sides of the coin, if you will. So hopefully that distinction, sort of continuous versus discrete, is helpful for folks to be able to conceptualize this difference. So as I mentioned before, this is adopted or adapted from what we call the whey methodology, the persistence methodology published by Dr. Whey et al. In 2014. And that is an empirically validated methodology, right? So it was found to correlate with meaningful outcomes like reduced A1C, reduced hospitalizations in Dr. Whey's original work and in PQA's own analyses in the Truven market scan data. So we do see that this measure correlates with the sorts of outcomes that we care about from a quality perspective. And to give you a complete picture here, we're going to walk through this methodology step by step. Rachel will go through the measure specifications after this. I want to make sure you don't confuse these with them. These are the steps of the methodology as they were done in the study. Rachel will go over how those were adapted into the measure specifications PQA has endorsed. But first of all, we identify patients with at least one refill of a basal insulin during the 12-month post-index period. Next, we calculate the number of days between the index fill and the first refill within the post-index period, stratified by insulin type and the quantity dispensed and the distribution. And then for all patients, starting from their index fill, we want to estimate the day's supply. We use the 90th percentile, but Wei also looked at the 75th and 95th just for sensitivity analyses. And we essentially estimate the day's supply from that 90th percentile. So put another way, what we've done so far in this methodology is use the 90th percentile of days between index fill and first refill, stratified by type of insulin and quantity dispensed, to estimate days quantity based on the data. That's really the crux of this methodology, estimating the day's supply from the data, since the field in the prescription claim, as we've discussed, is not going to be reliable since insulin is an injectable medication. Now looking at the rest of the steps, so for an insulin fill, if there is a refill within the estimated days supply, the patient is considered persistent. The estimated days of supply for the refill is then recalculated based on the characteristics of the refill, right? Insulin, again, the metric quantity, the clock resets, if you will. You do this for each refill until the end of follow-up, and you do sort of truncate the end there. So if days supply extend past the end, the individual is considered adherent. But if you don't refill within that period, the 90th percentile of days supply, that's when you're going to be considered non-adherent, or rather non-persistent, excuse me. And the days of persistence would stop at the insulin fill day plus the estimated days supply. And what this looks like, it can be helpful to get a visual. This is what Dr. Wei published as the estimated days supply table. This example is for insulin glargine. But essentially what we have here is for each metric quantity in milliliters, for each type of insulin, so this whole table is for glargine, we look at the days from the index to the refill, and then we look at the distribution of those days, and the 90th percentile is where we're going to get our value. And really the thought is that by the 90th percentile of days supply, we're pretty confident that people who haven't refilled by this time have discontinued. We've really looked at the serious outliers here at the 90th percentile, and that's how we're sort of understanding the persistence piece of it. So the 90th percentile of days between index and refill for a metric quantity of less than 10 milliliters is 145. You can see that in the top row of the table, in the metric quantity column and the 90th percentile column. And this table will evolve in our specifications into what's called the reference table, but this really is sort of the progenitor to that table, and was the approach that Dr. Wei took in. But to wrap this up, before we pass it over to Rachel to get into the nitty-gritty of PQA's specifications and also walk through some examples that I think will be really helpful for you all to understand this logic. We do want to reiterate the empirically based nature of this. We tested this very rigorously, both in our normal measure testing process, but also in research studies. So what we found was in alignment with what Dr. Wei found, and that was persistence is associated with lower A1C, lower healthcare utilization, higher pharmacy costs, which is to be expected because they received more insulin. That's almost a given, but lower total healthcare costs as a result of better managed diabetes, leading to fewer hospitalizations, ED visits, other expensive unplanned care. There were also no differences in hypoglycemic related events between persistent and non-persistent groups. And what we found in that also aligned with Dr. Wei's findings. Really the only difference actually between PQA and Wei's original study was that we were able to reach that threshold of being able to say we did find a significant decrease in total healthcare costs. So that's actually even a stronger finding than Dr. Wei's, which just sort of speaks to the evidence base around this measure. When we know that a quality measure from testing in real world data associates with, correlates, predicts the things that we care about in this population, that's when we know that this is in fact a good measure. So with that, I'm going to go ahead and pass it over to Rachel to take you all through some more specifics about the PQA measure.
Thank you, Ben. Just doing a quick sound check. Can you hear me okay?
Good.
Good. All right. Thanks. So, well, thank you to Ben for the background information. That's been very helpful. We want to go ahead and take a minute to review the persistence to basal insulin measure specifications a bit more in depth. So let's take a look at the actual specification overview. So on this slide displays the core components of the persistence to basal insulin specification, including the measure description, denominator, numerator, and exclusions. Might have to move to the next slide. I'm still seeing the title slide. Thank you. So the persistence to basal insulin measure, as Ben mentioned, evaluates the percentage of individuals 18 years or older who were treatment persistent to basal insulin during the measurement year. The measurement year is defined as the calendar year, which is January 1 through December 31st, and that's when the measure is assessed. The denominator is individuals who are 18 years or older with one or more prescription claims for basal insulin during the measurement year. The numerator is the number of individuals with continued use of basal insulin throughout the treatment period. So that's individuals that have all their refills for their basal insulin occurring on or prior to the expected refill date. Exclusions for this measure include gestational diabetes, hospice, and end-stage renal disease, as well as individuals with one or more prescription claims for mixed insulin, and individuals with one or more claim for regular insulin U500. The intended use is for performance measurement for health plans. Data sources are medical and pharmacy claims, and a higher rate indicates better performance. So as Ben previously mentioned, the reference table is needed to estimate the permissible gap between basal insulin fills. The reference table is empirically derived, meaning it's based on relationships that are observed in the data. And also, as Ben previously mentioned, the way methodology is used to calculate the reference table. Excuse me. Using prescription claims data from a representative data set from a broad population, the measure uses the 90th percentile to determine the upper limit for days between refills. And that's specific to each type and quantity of basal insulin filled. The expected refill date is calculated using the upper limit. And if a prescription has not been refilled by the expected refill date, the individual is considered to have discontinued or not filled their basal insulin and would thus be considered not treatment persistent. So some of you might be asking why the 90% threshold is utilized. The 90 percentile represents, as Ben has discussed, it's an upper limit that suggests that someone has discontinued the medication. This threshold was chosen to align with the existing evidence and was supported through consensus by the PQA Insulin Persistence Task Force. So next slide, please. Now let's review the persistence to basal insulin measure calculation steps a bit more in depth. So this content, it's a bit more technical, but the components of the measure are important to understand. So I'm going to spend a little time later on in the presentation also reviewing an example of how to calculate the numerator to help reinforce the concepts that are presented here. So first, to calculate the eligible population for the persistence to basal insulin measure, you first want to identify all individuals 18 or older as of the first day of the measurement year. As I mentioned, that's the full calendar year, and that's when the measure is assessed. Next, you want to identify individuals with one or more prescription claims for basal insulin during the measurement year. Then you want to determine each individual's treatment period, which begins on the date of the index prescription start date, or the IPSD, and extends through whichever comes first, the last day of measurement year, death, or disenrollment. And then you want to identify individuals with a treatment period of 91 days or more during the measurement year. That's not all. So after you identify the individuals in the treatment period of at least 91 days during the measurement year, Next, you want to identify individuals meeting the continuous enrollment requirement during the treatment period. Then you would identify individuals with one or more prescription claims for basal insulin with an expected refill date during the treatment period. Reminder, the expected refill date is calculated using the data fill and the appropriate permissible gaps in days from the reference table to estimate the expected refill date given the insulin type and metric quantity. And then finally, you will exclude individuals who meet any of the following that I previously discussed, so end-stage renal disease, gestational diabetes, or in hospice care, or those who received at least one prescription claim for mixed insulin or a regular insulin U500. And this will leave you with your eligible population for the persistence to basal insulin measure. Now that we've reviewed those key steps in determining the eligible population, let's turn our attention to the steps necessary to calculate the numerator. Okay, so for the numerator, excuse me, we want to determine the number of individuals with continued use of basal insulin throughout the treatment period. The first thing you want to do is identify all prescription claims for basal insulin within the treatment period from the individuals in the eligible population, so the denominator. Next, for all basal insulin prescription claims, you calculate the adjusted metric quantity by multiplying the metric quantity reported on the prescription claim by the associated conversion factor. Then, for all basal insulin prescription claims, you want to calculate the expected refill date using the appropriate value from the reference table. Those are based on line of business, type of insulin, and adjusted metric quantity to estimate the day supply. The next step is for all basal insulin claims with an expected refill date within the treatment period, you want to identify if a refill occurred on or prior to the expected refill date. Then you identify individuals with all refills for basal insulin claims occurring on or prior to the expected refill date. That can be for the same or different types of basal insulin. These individuals are considered treatment persistent. And then the last is to count the number of individuals who were treatment persistent during the treatment period. So that summarizes the steps for calculating the denominator and the numerator. And that is a lot of technical information about the core components of the persistence to basal insulin measure. And we thought it would be useful also to walk through an example of calculating the measure numerator in a step-by-step process. So next slide, please. So let's take a look at an individual example to better understand how to calculate the numerator. As you can see on this slide, the individual in this example has eligibility from January 1, 2022 through December 31st, 2022. They have 4 prescription claims for basal insulin in 2022. And you can see in the table on the right-hand side of the slide that the individual has prescription claims for insulin glargine on February 10th, May 8th, August 2nd, and December 1st. And each of those claims was for glargine U100 and a metric quantity of 9. Next slide, please. So next, we want to determine the estimated day supply. So we would evaluate the associated reference table to determine the estimated day supply based on the metric quantity dispensed. So in this case, the insulin glargine that was dispensed had a metric quantity of more than 6, but less than or equal to 9. And so according to the table, the reference table, this particular individual would have an estimated day supply of 91, according to the reference table, which you can see there highlighted in yellow. Next slide, please. Okay, so then you want to use the estimated day supply to determine the expected refill date. So as you can see on this slide, for this individual who filled insulin glargine on February 10th, 2022, you add the estimated 91 days from the February 10th, 2022 fill date, and the expected refill date would be on or before May 12th, 2022. The same process occurs for the next basal insulin date of service, which for this individual in this example occurred on May 8th, 2022, for a metric quantity of 9 and an estimated day supply of 91. So the expected refill date from that date of service would be on or before August 7th, 2022. Next slide, please. Next slide, please. Oh, thank you. Okay. Sorry, you were right. So on this slide, you can see the actual fill dates based on the date of service column on the left, and the comparative expected refill dates, which we just reviewed how to determine, and those are compared to the actual refill dates, and those are on the far right-hand side of this table. So this individual filled insulin glargine on February 10th with an estimated refill date of May 12th and an actual fill date of May 8th. Then from the May 8th fill, they had an expected refill date of August 7th, 2022, and an actual refill date of August 2nd, 2022. Then if you look at the August 2nd, 2022 date of service, they had an expected refill date of November 1st and an actual refill date of December 1st, 2022. So the question is, was this individual persistent to their basal insulin? So let's review. Next slide, please. So for this specific example, even though the individual filled their first 2 basal insulin claims on or before the expected refill dates, as you can see on the August 2nd date of service, they missed their expected refill date of November 1st and instead had an actual fill date of December 1st. So this individual is not persistent to basal insulin. Thank you. Okay, so also as mentioned previously, when reviewing the numerator calculation steps, it's important to note that if an expected refill date does not fall within the measurement year, it should not be included in the assessment. So for the individual in this example who had an insulin glargine date of service fill on December 1st, so that bottom left corner you can see they filled on December 1st, the expected refill date associated with that would be in March of 2023, which is outside of the measurement year and would not be included in the assessment. Next slide, please. Thank you. And then this slide is a visual representation of the previous 5 slides that we just discussed. It's displaying longitudinally the events that occurred for those that might be more visual learners. So just to orient you, as you can see, this is basically a timeline, and the actual dates of service are listed chronologically in the middle. So that's the February 10th, May 8th, August 2nd, and 12/21, and then, 12/1/22, and then the expected refill dates are identified underneath the actual dates of service. So those are the May 12th, August 7th, and the 11/1/22 actual fill dates. So if you scroll from left to right on the timeline, you can see that each unique color indicates a basal insulin episode for assessment. Like the orange indicates the actual date of service for the basal insulin fill on February 10th and an expected refill date on May 12th. And in that episode, the individual actually filled their glargine on May 8th. Same for the next episode in blue. That person filled on or before the expected refill date of August 7th. However, for the purple colored episode, you can see the individual did not fill their glargine by the expected refill date of November 1, and that's demonstrated by the gap you can see between the purple and the green. So hopefully that helps provide another way to kind of interpret this information. And now we'd like to spend the rest of the time reviewing some frequently asked questions that we have received related to the persistence to basal insulin measure. I think I'll turn it over to Lynn.
Yeah, great. Thanks so much, Rachel and Ben, for going through all of that really important information regarding this persistence to basal insulin measure. So as Rachel mentioned, part of our team's work that we do is supporting our measure users, and part of that is responding to any of the questions that come in. So what we've compiled here for the next few slides are just some of the questions that our team has been asked, or FAQs, if you will. Some of them aligned with the reference table, but I'm going to have Ben and Rachel address some of these questions. So Ben, this first one I'm going to toss over to you. So why isn't the methodology for calculating the reference table included in the PQA measure manual?
Yeah, thanks, Lynn. And this is definitely one that we get a lot. So I think it's a great chance to sort of provide a clear answer here. So this measure, the persistence to basal insulin measure, really was developed as a health plan performance measure. And it's intended to be used in a health plan performance program. Think something like the Medicare Part D quality programs. And because of that, the program administrator, the person running a given quality program, really would need to use data from all of the plans in that program to create the reference table and then calculate the measure rates for each individual plan. So if an individual plan were to calculate their own reference table and then try to generate a measure rate based off of their patient's sort of persistence scores, that data really would not reflect what you might expect to see in a larger program. So it really does require that population level data to be able to accurately infer the number of days supply associated with a given metric quantity and type of insulin. So all that's to say, to avoid the confusion and what we see as potential for sort of misapplication and misinterpretation of the measure, we do make that methodology and reference table only available on request. There's also actually a distinction to be drawn between accessing the methodology and accessing the reference table itself, because a reference table is specific to a given implementation of the measure. For example, a reference table in a Medicare program may look very different than one in a commercial program, because those populations are different and their insulin use patterns and refills may be different. So again, the point is to avoid confusion and potential misinterpretation. And that's why that methodology is available on request, but not just sort of put out there in the specs currently.
Thanks, Ben. So Rachel, another question that, as you know, we often receive. Why is the reference table needed? Why not use the day's supply on prescription claims? And I know you guys touched on this during the presentation, but given that we do get this question frequently, I think it's worth kind of reiterating and emphasizing some of those key points here.
Yeah, we do get that question a bit. So hopefully by now we've sufficiently addressed the question, but as described previously, the measure does not rely on the day's supply on the prescription claims due to potential variability in dosing of insulin and concerns with the accuracy of the day's supply. So instead, the measure leverages the associated reference table using the adjusted metric quantity of the claim to estimate the day's supply to determine the expected refill date. And I think we've mentioned this before, but the reference table is derived from real world refill data specific to the type of insulin and the quantity dispensed. So hopefully that summarizes a lot of what we just spoke about before to answer that question. So thank you, Lynn. Great.
Thank you, Rachel. And Ben, I think we'll go back to you next. So our next question, what is the adjusted metric quantity and why is it used in the reference table?
Yeah, so this is a great question too, Lynn. And really what it gets at is that not all metric quantities of insulin are created equal, right? Insulin comes in different concentrations. When we think clinically, getting 10 milliliters of U100, that's not the same thing as getting 10 milliliters of U200 or other different strengths or formulations. So when we have this reference table, we need to make sure basically we're comparing apples to apples when it comes to the quantity. So that's where this concept of adjusted metric quantity comes from. This is sort of a universal unit for the measure, and that unit essentially is units of U100. So we could say that 20 milliliters of U100 is the same metric quantity, adjusted metric quantity, as 10 milliliters of U200. You just want to go to that base 100, and that's going to allow us to make sure that we're all sort of speaking the same language in the claims when there are claims for the same type of insulin, but in a different strength. It allows us to be consistent.
All right. Well, thanks so much, Ben. And with that, I believe this is where we will move on to our Q&A portion of the webinar. And so just as a reminder, if you have any questions, if we can move to the next slide, please. If you do have any questions, please, again, submit them using the Q&A feature that is at the bottom of your screen. And then we will be reviewing those, and I'll be tossing them out to our presenters to respond. So first question that we have, Rachel, I'm going to hand this one over to you. The question is, it's kind of a two-part question, actually. First, does CMS plan to include the persistence to basal insulin measure as a star ratings measure? And if so, what is the process for it to become a Part D stars measure?
Well, that's a great question. So, okay, so I think as a reminder, it's good to note that the advance notice and final rate announcement serve as the vehicles that CMS uses for announcing potential new measures and program changes. And they also use those to solicit feedback on proposed changes. And ultimately, any substantive changes to the star ratings programs will go through rulemaking. So any measure considered for Part D must be on the display page for at least 2 years before it can move into the star ratings program. And at this time, the persistence to basal insulin measure is currently on the CMS patient safety reports. It's planned to be added to the display page for 2024. However, PQA does not have insight into any plans CMS may have for the measure beyond 2024, including potential future use in the star ratings.
Thanks, Rachel.
Sure.
So I think we will go to Ben with our next question. So Ben, will the reference table be based on each plan's data or aggregate data by business segments?
Yeah, so I like these questions that are coming in, Lynn, because we've seen before we got to the FAQs, we got a lot of questions that reflect the content from the FAQs. And I think that this one's sort of related. So it's going to be program by program, right? So it's not going to be, if the program were to cover all business segments, and when I hear business segments, I'm assuming lines of business, then that would be ultimately what's included in the measure. For Medicare, for example, that would only be relevant to Medicare plans, right? Because that's a quality program for that specific type of plan. So it is going to be all of the plans in a given program that are used to calculate the reference table, but the exact lines of business within a given plan, that's going to depend on the structure of the program.
Great. Thanks, Ben. Rachel, I have a question for you. So this question is, if the physician changes the dose, for example, decreases it by informing the patient, so in essence, they did not write a new prescription, would this impact the persistency measure?
Another good question. So this particular situation was built into the data used to calculate the 90th percentile. And so we, I guess, would use all data in these situations to determine that reference table. So I guess, yes. that answers the question.
Okay, let's see. We've got another question. Ben, how about if I toss this with you to you? We'll do a little kind of ping pong between the two of you. So Ben, when the question is, when we determine if a member filled within the expected refill period, how do we treat it if they switch to a different strength or insulin type? Is that considered an on-time refill?
Yeah, so that's a great question. Really, the way that it works is each time you get a refill, you're effectively sort of restarting the clock, and you now have a day's supply estimation based off of that refill. So if you changed the strength of the patient's insulin prescription and they filled that new change, and it's a longer day's supply, you would see after that refill, they now have a longer day's supply to get the next one. Now, their existing fill before they change prescriptions would not be affected, because what we're seeing from that fill is still the number of days supply that patient had. You know, if they get a prescription for a different insulin, but fill it way after we think that their days supply has been exhausted of their previous fill, they're still going to be considered non-persistent, right? They're going to be well beyond the 90th percentile. We're confident that this individual is not persistent. So again, it sort of adjusts with each fill and the characteristics of each fill, including the adjusted metric quantity, which gets at the dose, and the type of insulin.
All right, thanks, Ben. Another question, let's see, does the quantity to days supply conversion need to be updated for new product formulations?
I can jump in and then maybe you can follow up, Rachel. So essentially, if I understand the question, I think it's yes. So as new product formulations come out, we will see them in the data used to generate the reference table. So if a new insulin comes to market, we will use this methodology to estimate the day supply associated with various metric quantities of that insulin. And then that would be the value used in the reference table. So the reference table is not necessarily static by any means. It's subject to change as new medications come to market, or if use of insulin patterns change. The whole point of this is that it's at the population level. So it's trying to infer from all of the data available what is a reasonable day's supply after which we are confident that individuals have discontinued. Again, that's where the 90th percentile comes, right? So there's a lot of slack getting to that 90th percentile. At that 90th percentile, there have been a lot more days supply than most people would expect to have for a given insulin fill.
Yeah, I can jump in here too. Thanks, Ben, for taking that. So I think it's just to note that the reference table, it's grouped by insulin ingredient and quantity, not formulation. So just wanted to clarify that. Hopefully that will help address the question.
Great, thank you. Thank you both.
Mm-hmm.
A next question that I will toss out. Let's see, so this is more clarification. So just to clarify, the measure uses a standard for refill based on a large amount of claims, correct? Or is this individual to each patient and their filling habits?
It is the prior. It is based off of all of the claims in a given program. So it's using that maximum amount of data to draw the best conclusion we can about the day supply associated with a given fill.
Great. And let's see, another question. So in reference to our the study results, so is the PQA study, are the PQA study results available for the basal insulin program?
All yours, Rachel.
Yeah, so I believe, is that in reference to the publication? Sorry, I want to make sure I'm understanding the question. Okay, thank you. So yes, we will be publishing the information from the study It's not quite out yet. It will be eventually, hopefully soon. How's that? Good.
Great. Yeah, I believe it's currently in kind of final reviews, and a publication will be forthcoming. So
Yes.
we will be sure to make that information available as to how to access.
We're excited to share it.
Yeah.
Yeah, absolutely. I believe that has covered the questions that have come in so far. Excuse me. Unless anyone on the team is seeing additional ones. I'm just going to take a moment to scan.
I think that one question I can answer, Lynn, is the one that came in just a minute ago. How is the measure impacted by an individual's insulin resistance, right? That can vary widely. And I think this gets to a concept that sort of addresses a lot of questions, which is that basically all of these individual factors, right, that can vary. These individual factors are the reason we can't really use day supply in the first place, right? It's this dosing and the timing is variable. So all of these individual factors, using the population level data is how we get around that. So in this instance, if a given individual's insulin resistance varies widely, if a lot of individuals have that, it'll be reflected in the data and the 90th percentile will be pushed out. So if that insulin resistance is causing their insulin fills to have fewer days supply, that's going to push out the acceptable number of days supply for a refill in the reference table. So a lot of these individual variance factors are ultimately captured in the methodology. That's sort of how the methodology works. And when you're dealing with an entire program, that's why you get to numbers where you are comfortable about the conclusions being drawn. It's also one of the reasons why we cautioned against sort of use of this by an individual health plan or some smaller entity. You need a sufficient sample to be representative and to draw good conclusions about the day supply. So hopefully that is helpful.
All right. Thank you, Ben. Before we begin to wrap up, I'm going to check to see if we have other questions here.
Yeah. So Lynn, one that came in, sorry if you can hear me, one that came in, but I think was kind of addressed in what Ben was saying was, I think somebody asked if the member fills their insulin early, are there adjustments for their next refill? And the answer is yes, that's built into the empirical data used to calculate the reference table. So if you call back to our example that we went through, you have their the actual claim date for the fill, and then you do the estimated, and then you take the date that was actually filled, even if it's early, and you use that for the next assessment. So hopefully that helps address it. And I think Ben kind of mentioned it too.
Exactly. That's exactly the sort of question that the same answer would apply to.
Yeah. Thank you.
One more question for Ben. What is considered an adequate population for this measure?
That is an excellent question, and one that I'm not sure we'd likely be able to answer on the spot. You know, the two rounds of testing, what Whey tested in, what PQA tested in, were very substantial populations. Obviously, the current implementation in Part D programs is also a very, very large number of patients. It could be a possible future area of exploration to see how small you can get and still be confident. There are some nuances of how the reference table works when you start reducing the number of claims. So as the claims get removed, you might have noticed that the reference table has ranges of metric quantity. So you want to make sure that you don't have really small cells. If you only have one insulin with an adjusted metric quantity of 10, you're not very confident about it. So you roll it into a range where you have higher confidence. But as the population gets smaller and smaller, your confidence gets smaller and smaller. those ranges start to expand because you need to include a larger range of values to be confident in them. So this is a long way of saying that we don't have an exact answer to that. It's something that we would certainly, in implementations of the measure, we'd want to have a discussion with the program administrator, make sure that we're all on the same page, that we're confident about the ability of the measure to draw conclusions in this population. And there could also be, some poking around, some analysis to support as well.
Great. And Rachel, I think you may have covered this, but a question we received is, how do you request the reference table, and is there an additional fee for this?
So I think we addressed it already, but the plan administrators are the individuals who are creating the reference table. So we, like PQA, we don't have the reference table. So you would want to talk to the program administrator, I think, to get the reference table, unless there are other suggestions.
Yeah, so for the Part D program, it is available to plan sponsors, as I think Rachel mentioned, through the portal.
Through the patient safety reports.
Exactly. It's definitely good to get in the habit of talking about the reference table within a specific program. So sort of as we've been saying, how do I get the reference table? Well, there is no the reference table. There's a reference table for the measure used in Medicare.
Yeah.
But so that's just sort of a tip to help maybe make us answering technical questions a little easier. There's no one reference table. It's specific to a given population.
Thank you. Yes.
Getting our money's worth out of these questions, huh, Lynn?
Absolutely. I've been scrolling through. You guys are doing a great job of responding. So thank you for that. And thank you to our audience for being so engaged in asking these questions. I think we have gotten through our list at this point. So if we can move on to our next slide, just to have a few additional announcements before we wrap up today's webinar. So first, we hope to see you all at our fourth quarter stakeholder advisory meeting, which is scheduled for next Wednesday, October 26th from 1 to 2 p.m. Eastern Time. Please do visit our PQA website to register for this webinar, and then join us to hear updates on measure development and maintenance, member engagement opportunities, including those related to the measures that currently are being considered for endorsement and retirement. And then please also join us for our next Quality Forum webinar. Moving to the next slide, which is our next Quality Forum webinar is going to be held on Thursday, November 17th from 1 to 2 p.m. Eastern Time. This particular webinar is a members only webinar. The registration link can be found in our member resources library on our website. So please do visit that and join us on November 17th. And for that particular Quality Forum, we will have Andrew Thorne from PQS joining us to provide an update on the 2023 Medicare star ratings. This is kind of an annual webinar that we do every November. So kind of backed by popular demand. It is always well attended. So we hope you all can join us for that as well. And then lastly, as a reminder, please do share your feedback on today's webinar by responding to the survey that will open at the conclusion. And your feedback is really important to us. We do utilize it to shape future programming. So please just take a moment. It's just a 1-minute survey, and we will look forward to your feedback. And so this concludes today's webinar. Again, thank you, Ben and Rachel, for all of the information you shared today, including responding to the several audience questions that we received. And thank you to each of our attendees. We appreciate you joining us for this webinar. We hope it was very informative to you. If we didn't get to any questions or if any come up at a later time, you can certainly submit those through our technical assistance form. And with that, we will conclude for today.